Uterine fibroids, medically termed leiomyoma, fibroma, or myoma, but commonly known as fibroids, are benign, non-cancerous tumors that grow within the muscular layer of the uterus. Fibroids are composed of muscle and fibrous tissue, which give them a firm texture. Fibroids are the most common of benign tumors found in women. They usually occur during the middle or late reproductive years of a woman, although some young women in their 20s also develop fibroids. These tumors usually come in multiples and can vary hugely in size, from a tiny pea size to larger than a melon. Fibroids are classified according to the location where they grow within the uterus. There are three main types of fibroids: submucous fibroids, intramural fibroids, subserous fibroids. Submucous fibroids are fibroids that grow towards or just beneath the lining of the uterus, the endometrium. Intramural fibroids are fibroids that grow deep within the muscular wall of the uterus. Subserous fibroids are fibroids that grow towards or just beneath the outer layer of the uterus. Some fibroids are attached to the uterus by a thin stalk called the peduncle. These fibroids are generally known as pedunculated fibroids. Pedunculated fibroids can be subserous pedunculated fibroids, submucous pedunculated fibroids, or cervical pedunculated fibroids. For fibroids that grow within the cervix, which are relatively rare, they are known as cervical fibroids. The actual cause of fibroids cannot be completely determined. Factors such as hereditary, race, and estrogen level, however, are conclusively linked to the disease. It has been found that many women with fibroids have a family history of the disease. It is believed that fibroid arises from the mutation of a single muscle cell which exists from birth. Researchers have suggested that women with African American ethnicity are 2 to 3 times more likely than other women to develop uterine fibroids. Although the actual reason behind this heightened likelihood is unknown, it has been speculated that the genetic predisposition could play a role in it, since it is common for African American women to develop fibroids at a younger age. These women also tend to have multiple and large-sized fibroids. Many women who develop fibroids are also found to have elevated estrogen levels. While it is unclear how estrogen contributes to the origin of the disease, it has been confirmed that fibroids do depend on the hormone to grow, just like endometriosis. This also explains why some women experience worse symptoms of fibroid during perimenopause, as their estrogen levels are abnormally high at this stage. The symptoms, however, settle down naturally at menopause due to a significant decline in estrogen levels. Under estrogen deficiency, fibroids usually shrink and sometimes disappear without treatment. Many women with fibroids do not experience any unusual signs or symptoms and mostly only discover the existence of the fibroids incidentally during a routine pelvic or ultrasound examination. Nevertheless, appearance of symptoms is certainly possible and can sometimes be highly troubling. The most common symptoms of fibroids are heavy and prolonged menstrual bleeding, pelvic pressure, pelvic pain, infertility. Women with fibroids are likely to experience abnormally heavy and prolonged menstrual bleeding lasting 7 days or more, which can lead to iron deficiency anemia. This symptom is widely believed to be caused by the inability of the uterine muscle to contract effectively to reduce menstrual flow due to the presence of fibroids within the muscular wall of the uterus. Women with large fibroids may feel a sense of fullness or pressure in the pelvic area as the fibroids pressed against the surrounding organs such as the bladder and rectum. These may even damage the organs. The symptoms of this kind of pressures are difficulty in urinating, constipation, dilation of the kidney with urine known as hydronephrosis. When the fibroid presses on the bladder capacity is reduced. Consequently, the subject may have the urge to urinate more frequently or feel incomplete bladder emptying. In rare cases where the urethra is blocked, the subject will experience acute urinary retention. Constipation occurs due to pressure of a fibroid on the rectum. Occasionally, the fibroid presses on the ureter and obstructs the passage of urine from the kidney to the bladder. The urine will start accumulating behind the obstruction and eventually distend the entire kidney. This is known as hydronephrosis and can result in urinary tract infection and or even permanent damage to the kidney. There are a few reasons why fibroids cause pain in the pelvic area. They are fibroid degeneration, twisted peduncle, fibroid infection, and malignant change. When a fibroid grows to a size that its blood supply is no longer sufficient and blood can no longer reach the fibroid's central area, it will start to degenerate from inside. In other words, the muscle tissue that makes up the fibroid dies due to lack of oxygen. The process will cause severe pain that usually lasts between several days to a week or even more. When a pedunculated fibroid becomes twisted, it can cause excruciating pain to the sufferer that an immediate surgery to remove the fibroid is required. Another situation that can occur is that twisting blocks the essential blood supply to the fibroid, resulting in fibroid degeneration, which in itself is very painful. Occasionally, a degenerating or dying fibroid can infect the surrounding uterine tissue, causing pain. Very rarely does a fibroid evolve into a malignant or cancerous tumor called leiomyosarcoma. There is a 1 in 1,000 chance of this occurring. When this does happen and the malignant tissue starts to invade the surrounding uterine tissue, it can result in intense pelvic and abdominal pain, which may be accompanied by abnormal vaginal bleeding. Fibroids growing in the fallopian tubes can compress and block the passage of the egg and sperms, making fertilization impossible. Also, fibroids growing within the muscular wall of the uterus may severely distort the uterine cavity, especially the endometrium, and interfere with the blood supply to it, making implantation difficult or impossible. Diagnosis of a uterine fibroid can be made by taking a good medical and family history, pelvic examination, ultrasound, magnetic resonance imaging, hysteroscopy. Taking a good medical history can lead to a suspicion of uterine fibroid. Since fibroids tend to run in families, a patient's family medical history is significant in helping a gynecologist determine the likelihood of fibroids. Fibroids of asymptomatic patients are usually discovered during their routine pelvic examinations when the gynecologists find round and lumpy masses in the lower abdomen. However, the presence of fibroids cannot be confirmed via pelvic examination alone, as other diseases such as adenomyosis or ovarian cysts, especially if lumps are felt on the sides of the lower abdomen, can be mistaken for fibroids or the other way around. Other assessment techniques such as reviewing the patient's family medical history, ultrasound scanning, and magnetic resonance imaging (MRI) are required to corroborate the diagnosis. Most fibroids are easily detectable with ultrasound. The scanning can be performed either abdominally or transvaginally, that is through the vagina. A transvaginal ultrasound can provide greater clarity of the size and location of each fibroid because the probe is closer to the uterus. The ultrasound results combined with the findings of the pelvic examination are usually sufficient to diagnose fibroids. Sometimes an MRI may be required for definite confirmation. MRI is so far the most accurate diagnostic tool for fibroids. It provides much more detailed images of fibroids than the ultrasound, enabling a gynecologist to determine the exact number of fibroids, their size and position, as well as the degree of anatomical distortion of the uterus and its surrounding organs caused by these fibroids. Hysteroscopy is a technique that allows a gynecologist to directly view a patient's uterine cavity by inserting a narrow tube-like telescope called a hysteroscope attached to a camera into the uterus through the cervix. It is very useful for assessing submucous fibroids and the overlying endometrium. This technique is usually necessary for patients who claim to have abnormal vaginal bleeding and/or recurrent miscarriage. Surgery is considered the standard treatment for women suffering from fibroids. Two most common procedures to surgically remove fibroids are hysterectomy and myomectomy. Transcervical resection of the fibroid can be performed in small submucous fibroids. An alternative to surgery is uterine artery embolization, UAE. Hysterectomy is the procedure of removing the entire uterus, including the cervix. This can be performed either laparoscopically or by laparotomy. Hysterectomy is usually an option for women who have completed their family and are above 40 years of age. The advantage of hysterectomy over myomectomy is that it eliminates the possibility of fibroid recurrence and put an end to all symptoms, including heavy menstrual bleeding, which may persist even after a myomectomy is done. Myomectomy is a procedure of removing the fibroids without removing the uterus. It can be performed either laparoscopically or by laparotomy. The main advantage of myomectomy is that it allows a patient to conceive in future. One disadvantage of the procedure is that it may cause considerable blood loss during surgery that blood transfusion may be necessary. Other disadvantages are the possible recurrence of fibroids and the possible persistence of heavy menstrual bleeding after surgery. In cases of recurrence, subsequent myomectomy will be more complicated, as the previous one may have led to formation of adhesions. In submucous fibroids, hysteroscopic resection of the fibroids can be performed. This is usually done when the submucous fibroids are small. An instrument called a resectoscope is used to cut the fibroid into small pieces until the base of the fibroid is reached. The small chips of the fibroids are then removed through the vagina. Uterine artery embolization is conducted under a moving X-ray known as a fluoroscopy by an experienced interventional radiologist. It is a procedure where a tiny tube called catheter is inserted through an incision in the groin area into the femoral artery and then threaded to the uterine arteries. Some tiny sand-like gelatinous particles will be injected into the uterine arteries through the catheter in order to block the blood supply to the fibroids. The blockage or embolization will eventually result in the degeneration of the fibroids. The advantages of UAE are minimal blood loss, fertility is not affected, and the recovery period is short. The disadvantages are that patient may experience post-embolization syndrome such as severe pelvic pain and cramping, as well as nausea and vomiting that last for several days following the procedure. Embolization may cause damage to the uterus and uterine infection may also occur. When the fibroids begin to degenerate, they can cause severe pain to the patient. As fibroids normally lyse or self-destruct by themselves after menopause, surgery is usually not recommended for small fibroids less than 5 cm and asymptomatic fibroids. For these fibroids, no treatment except constant surveillance of their growth is required. In conclusion, fibroids are common benign tumors in women. They are usually asymptomatic and do not require treatment. When they become symptomatic, treatment